Okay.
Hi, everyone. Okay, we're live. Hi, everyone. I'm Susan Lowell de Solorzano, coming to you from Washington, D.C. And Chris, you are where?
Hi, Susan. I'm Chris Morita Clancy, and I'm coming to you from Deep Cove on the unceded territory of the Coast Salish Nation. This is just outside of Vancouver, BC in Canada.
All right. And Graham?
Hello, I'm coming from Nottingham in the UK.
All right. And we're your hosts for the Biotensegrity Party, today featuring Dr. Elizabeth Ewell, otherwise known as Betsy. I think she's very comfortable being less than formal, yes?
Yes, definitely.
And Betsy, are you in Athens?
I'm in Athens, Georgia, yes.
That's wonderful. And Betsy has agreed to open up today's gathering with a toast.
So I have a toast, have my mug here, and I actually have to toast a couple of people that are present today that have been an inspiration. One is Michelle Osborne, who's my cohort in crime on this project, and the other is you, Susan, because half of this project actually was inspired by your book. So cheers to everyone.
Oh my gosh.
Cheers.
Thank you.
Yeah.
Wonderful. So Betsy, before you start your presentation, can you just tell us a couple of things about yourself? Like, where'd you grow up? Were horses always part of your life? Was medicine always part of your life?
Well, I grew up in Ithaca, New York. Both my parents were Cornell professors, so I was a faculty brat. I have had horses and worked with horses for longer than I'd like to admit. Had an interest in science and medicine and ended up going to veterinary school. And once I got into veterinary school, I decided that the disease was more interesting than the cure. So I became a pathologist. And the other nice thing about being a pathologist is that I've looked at disease in everything from cockroaches to elephants. So it's really a very broad perspective, which is something I've been interested in. So I've been, went to Cornell vet school, went to the University of Florida for residency and a PhD, and then am now on faculty at the University of Georgia.
Wow, that's great. And it's beautiful up in Ithaca. That whole Finger Lakes region and stuff is really lovely.
Yeah, except for the winter being a bit long.
Now you're spoiled.
Athens has a lot of the charm of Ithaca without the weather. Because it has a long spring and a long fall, but Ithaca is a wonderful place to grow up.
And my second question before we start the presentation is, how did you stumble onto Biotensegrity?
Well, I'll be talking about that as I go through the talk a little bit. I'll show you how we got into it.
Great.
Part of the talk will be a short recap of some of our horse work, which we heard before, but it was really what got me into, and us really into, biotensegrity, was trying to answer questions about degenerative joint disease in horses. So
that's great. For those of you who don't know, Betsy and Michelle, and also Celeste is here, who was part of that, and Marin. We did a great, and George, I see George. Hi, George. We did a really amazing colloquy on equine health, biotensegrity and equine health back in July, and that is now freely viewable on the archive YouTube channel. So I will ask those not presenting to turn their cameras off, and we will turn it over to you, Betsy.
Okay, I'll start share screen. And okay, so, okay, can everybody see the screen?
Yeah, it looks good.
Okay, well, this is a kind of a short recap of some of the things I'll be talking about as we move on. But let me first talk about, as you probably are aware of, let me see if I can get rid of some of this, is that how we how knowledge advances really depends on how knowledge advances is that we have theories that focus the research, and those theories provide assumptions for which science is done. Then there'll be technology that enhances the testing of these theories. And then as we test the theories start to drift. They don't explain things very well. And eventually we have to shift them. And right now, we really need a big shift away from the body as machine model. And the Biotensegrity model really provides a much better answers to things. But we really have to justify these theories based on both available evidence, and also they have to be tested and proven in their application. So
before you leave that slide, Betsy, well, I just want to mention, for those of you who don't recognize it, the book in the lower right corner is Thomas Kuhn's The Structure of Scientific Revolution, which has been discussed a lot during our tea party. So thanks. I just didn't want anyone to miss that.
Yeah, good. No, because it's a very nice way of saying how science is done, and that also that we expect theories to fail. You get people that will defend them almost to the death, but science really progresses when the theories are failed. The other limit factor in terms of understanding things, and in particular structure and function, and in my case pathology, is that how things are studied can really limit our understanding. And I'm becoming more and more aware of this as I move on. When you realize that we've been looking at both the body, both normal function and pathology, a lot based on gross, what we can actually see, and then histologically. And when you think about what histology is, you're looking at a very tiny piece of tissue in 10 micron, two-dimensional view. And so what's been really exciting is that we have a lot of new ways of looking at tissue, and in particular bone, which hasn't been very well understood. But it's also important to realize that our understanding is based on how we've been able to study things, and that's been very limiting. And we'll see that all the way through. So my interest as a veterinary pathologist is whether Biotensegrity paradigm can really explain disease better in terms of what I'm seeing. And to start off with, my diagnostic interest is in bone pathology. So I've been studying osteoarthritis and degenerative joint disease. And as a pathologist, we like lesions. So what we've tended to do is to go, oh, look at the shiny, look at the pretty lesions are pretty to pathologists, of osteoarthritis. And then we have described them in almost numbing detail. And then and I was guilty of this too. When I was teaching degenerative joint disease, I would go, oh, here, look at all these nice lesions. And if somebody said, what did it? I would go mechanics next. And we just never really looked. So we had an assumption about how things were working that was based on the idea that our osteoarthritis, or what I prefer is degenerative joint disease, is due to structural and functional failure of the joints, basically wear and tear, and that the damage exceeds repair. Again, the symptoms, unfortunately, many of us are aware of. It's pain, lameness, and swelling. The lesions are damage to the bone and cartilage, inflammation, proliferation of the bone around the joints. And the standard treatments have been anti-inflammatories, painkillers, and surgery. Now, the important thing when you're really testing a paradigm and saying, maybe, we ought to think about things a little differently, is to start asking questions that challenge it. We have a tendency to kind of avoid those questions because they can't be answered by the current paradigm. So some of the questions that really test the paradigm of degenerative joint disease are, why does it get worse? Why doesn't the severity of the lesions always correlate with pain and lameness? And if it's caused by wear and tear, how come exercise helps patients regardless of the severity? And the thing is that if you start looking across, there's all kinds of evidence saying this idea that it's wear and tear can't be exactly right, because I have an interest in paleopathology. So I was interested in a study where they looked at the prevalence of knee osteoarthritis, early industrial and post-industrial, and actually as people were moving around less, they got more arthritis. And the people that were moving more had less arthritis. We also see that in terms of hunter-gatherers, lesions in hunter-gatherers versus farmers. They had a lot less arthritis. So the idea of wear and tear just doesn't fit very well. But if you ask a lot of people, why do you get arthritis? Well, the joints just wear out. But the real crucial question is, why do the current therapies, which have primarily till more recently been painkillers, anti-inflammatories, and cartilage repair, fail? And as you're all familiar with the Biotensegrity paradigm, for me, it really explained the lesions that I see in osteoarthritis. The lesions that you see are joint space narrowing, and that can be explained by the soft tissue tensegrity, meaning the tensegrity of the tension in the ligaments and joint capsules and others failing to keep the bones apart. Then as that destabilizes, you get bone spurs, or what's called osteophytes, that form in the attachment sites to compensate for the increased mechanical stress on these attachments. The classic lesions, that is what people have really been focusing on, occur when the bones in the joints come across and touch each other. And this is something, Dr. Levin has talked about before, but it beautifully explains this. The cartilage is very thin and it can't take any real compressive damage, and neither can the bone. So compression is particularly bad for tissues. But unfortunately, because of how we've looked at things, if you're looking at a joint that has arthritis, you see this and you see this. So there's been a real focus on trying to, quote unquote, fix the cartilage. And really, you've got to restore the tensegrity of the joint to take the compression off the cartilage. It really makes the paradigm work quite well. And it also answers the question that the body as machine paradigm can't answer. So when you look at the lesions of osteoarthritis, why don't they correlate with pain and dysfunction? Well, it's because it's a disease of mechanics, and in particular, failure of the joint tensegrity. It also means that some of the lesions are compensations. Basically, the bone that's growing into the attachment sites are ways of stiffening these attachment sites against the mechanical stress. So if they're successful, then the joint's stabilized and you may have these bone proliferations around the joint, but you don't really have a lot of pain. And again, if it's caused by wear and tear, why does exercise help? Well, because exercise is a way of restoring the proper joint tensegrity and the mechanics. And it also can relieve the symptoms at all stages. And it gives us, this has been coming out in the osteoarthritis literature, that, yet more evidence that osteoarthritis is a disease of mechanics, not a primary inflammatory disease, which is what people had thought for a long time. And they've realized that if you correct the mechanical forces, it's preventative, and it often makes invasive treatments unnecessary. Now, while this has been pretty well established in human medicine, or is getting more established in human medicine, it's not at all established in veterinary, which is one of our problems. So, and why are the paradigms important? Why is it how we think about it so important? Well, because it defines our options, both in treatment and in terms of how we investigate disease. So if you look at the body of machine paradigm, it's a lesion, it's based on lesions. The lesions are the primary cause. One question I often ask when I'm giving a talk is, which came first, the lesions or the lameness? And most people will say the lesions came first, okay? So it's very unfortunately firmly set in that the lesions are the problem, when actually they're a secondary result of mechanical failure. Based on the body of machine paradigm, the pain is caused by the lesions, and if you want to treat the pain, you treat the lesions. The disease is complex. I always like this term. If a disease is complex, it means that it doesn't fit what we think about it. In other words, in this case, okay, it's lesions, but you got lesions and no pain and lameness, so therefore it's complex. And what you see also, and I've read this in articles, is that we need more focus on the lesions. So we've been studying them in great detail for 50, 60, 70 years, and now we need to study them more. Instead of going, well, maybe we ought to think a little differently, but again, realize that the paradigm won't let them think differently. There's no other option in there, okay? The other problem with the body and machine paradigm and a focus on the lesions is that the options for treatment are really standardized and they're extremely limited. Just, okay, you've got a joint that's damaged, fix the damage in the joint and everything's fine, okay? They realize they can't really do that. So then they say, well, we can't successfully treat the disease. It's going to progress and it can't be effectively treated. For a horse, that's often a death sentence. In contrast, and I would submit that this alone is a good reason to switch paradigms, it's a lot more optimistic and gives us a lot more options, okay? So in the biotensegrity-based paradigm, the inability to manage forces is really the primary cause of pain and dysfunction. The lesions are secondary to this inability to master the forces or control the forces, and there are reactions. The pain is also an indicator of pending, and I put the word detectable tissue damage in there, remembering that in the beginning I said, okay, you've got to be careful because how we've looked at disease has colored our view of it. So for a long time in arthritis, the only lesions we could really look at were in the bone. So that's where we thought it was. Okay, now we're starting to see lesions in soft tissue. The other advantage to the biotensegrity paradigm is it greatly expands and individualizes treatment options, and it has a much more optimistic outcome, which is that the correction of the source of mechanical stress is effective long-term treatment. Instead of in the body of machine, they just say, well, we can manage it, but we can't treat it. So looking at this in terms of actual disease, we talked in the other forum about navicular syndrome, and this is the one that we've studied the most. And what this is you've got a horse that's got chronic pain in the heels, and you can see that in terms of how this guy's standing. And then if you look at, this is the navicular bone right here. This is the deep digital flexor that comes around and attaches to the distal phalanx right here. And what you see is that this bone is damaged. That was the first thing they picked up in horses like this, that the bone itself is damaged. They didn't really have either the imaging capacity, nor was it in our paradigm to look at the soft tissues for a long time. It's only recently we started to do that. So the current paradigm for navicular disease is that it's a chronic degeneration of the navicular bone, and I emphasize bone because that was for a long time all we could detect. It has a complex pathogenesis, which basically means we don't understand it. They think, okay, there's a biomechanical component, and something about conformation in the distal limb is often put out. And then this is, again, classic of the body as machine paradigm. It's chronic and degenerative. It can be managed in some horses, but it can't be cured. And the treatments are rest, painkillers, corrective shoeing, and cut the nerve. Okay, now, with the exception of painkillers, rest, corrective shoeing, and cut the nerve so they can't feel the pain, those treatments have been around for 150 years. So the only thing that's been added recently is anti-inflammatories or painkillers. And you would think after 150 years, maybe we could do a little better with this. And if not, maybe we ought to look at what we think's causing it. And again, the majority of horses become unresponsive to treatment. So, you know, when you've got, if the treatments fail, you need to think about the disease differently. And if you look at the way we've been studying navicular disease and treating it, this is it. You change the shoes, cut the nerve, find the gene. That's another one I particularly like. And so we started thinking about what we're calling pathomechanical loading, which is that there's too much force on the front legs of the horse. Maybe we ought to look up and try to assess what's going on. And that was what basically got us into Biotensegrity. Now, just to give you an idea of how much focus has, you know, biomechanics of navicular diseases from here down. So their only treatment therapy they have is to change the shoe. Okay, and I'm sure you can understand why that probably doesn't work. The other thing is because, again, they thought it was a disease of the navicular bone. They did measure pressure in the navicular bone, and the pressure within the bone was high, and it was high enough to induce pain. So you know what they decided to do about that? And this was published: drill holes in the bone to release the pressure. Needless to say, it didn't work.
Yikes.
That's what they did. I'm not kidding. Okay. Now, why this blindness, if you will, or blinkers? And the blinkers, again, have been put on by how we've been modeling the disease and how we've been looking at things. So when you go take anatomy, this is the kind of model you see of the horse's leg, but this is actually reality. So we created this with Velcro. All of this is being held together, tried to put the ligaments in the right place. But you can see how this gives you a very different idea about how that leg's functioning than something like this, where, you know, you've basically wired the bones together. So what we were doing, and this was work with Michelle, was to actually model the whole body to try to understand where these forces are coming from. And again, I've been working with Jean-Luc Cornille, who I have to say, he's the one that got me into this. I'd probably still be admiring lesions when I was teaching bone pathology, rather than trying to get into what's actually created them. And this is a picture of him working a horse with navicular disease. And what he had noticed was, you can see it here, the horse is tipped on its front end and this leg is way back. And he commented that when he successfully rehabbed them, that they went from this position to a more straight up position. So in an attempt to make a kind of tensegrity-like model of this, these are just muscle attachment sites drawn in as straight lines. And we're working on a more sophisticated way to model this. But even with that, you can see that this, you know, there's a big difference in how these legs are functioning. And we started again with, with Michelle's help. We started modeling, does this position change the forces on the navicular bone? And indeed it does, that we could do some force analysis to say that you change the position of the bone, you have a redistribution of forces, which is again something that would be predicted in the biotensegrity model. And then as a pathologist—
Betsy, what was that DDFT?
Oh, I'm sorry, that's the deep digital flexor tendon.
Oh, okay.
So what we found was, okay, here's the deep digital flexor tendon. It runs on, here's the tendon running behind the bone, and it attaches here. And if when there's stress put on this, some of the tensional stress of the tendon is transferred to the bone. Okay.
Thank you.
And when it's in this position, what we did was compare, what Michelle did really was compare the stress levels in the normal position to the stress levels in the abnormal position. And what she found was that there's more compression in the navicular bone, but in addition, to balance the forces, you had to put more tension on the ligaments that attach this bone to it. So we saw more compression of the bone and more tension on the ligaments. That was in the force analysis. so for me as a pathologist, I was going, okay, if you're talking about biotensegrity, you're talking about tension and compression. Can we explain the lesions we see by increased tension and increased compression? And indeed, we really can, because here is the navicular bone. This is a more normal bone. You can see it's kind of square. And here it is, you've got compression-induced damage. The other thing is that the force model said it's have increased tension on the ligaments that are holding the bone in place. And indeed, we see that as well, because you're seeing bone being laid down at their attachment sites. Remember, I talked about how osteophytes form in the soft tissue attachment sites. And this produces this, what they call canoe shape to the bone itself. So you have, here is normal, you're having increasing amounts of tension put on the ligaments. And then you reach the point where you're seeing bone growing into the ligaments. So we see increased tension on the ligaments, increased compression on the bone.
And
if
Betsy,
you actually, yep.
let me just clarify that on the left with the navicular bone, the normal healthier is the top, but
It's
on the
top.
right, the normal healthier is at the bottom.
Yes, sorry about that.
No,
Yes.
no, that's fine. Just wanted to make sure. Thanks.
Yeah, you can see that the bone here, I mean, this one looks squished and basically it's compressed, okay? Compared to this one, it's not as square up. And then again, we've got ligaments, we see increasing tension on the ligaments over here. If you actually look at it histologically, you can see this is the normal attachment site for one of the ligaments. And you can see it's got a nice braided structure or woven, braided, however you want to call it, as the collagen fibers transition into the bone. And the actual site where it transitions into the bone is a little hard to pick up because it's interlaced in, okay? What happens with increased stress on these attachment sites is that the collagen fibers and their tensegrity structure starts to break down. And that's what you're seeing here, okay? Now, I was thinking as a pathologist, gee, I wish we had a stain that would detect mechanical stress. Whoops, sorry. And it actually turns out we do. I was looking at a case in Navicular. And again, here's a horse's foot. We've got the navicular bone here. This is a plastinated section, so you can see the soft tissues in it too. Here's the tendon coming down, goes around the bone like this and attaches here. And there's a fat pad here. You can also see that there's damage right in here, all right? So I was looking at a case of navicular disease, and again, the flexor tendons coming down, and right about in here, they detected lesions in the deep digital flexor tendon, okay, that correlated with damage. This was by MRI. And so we were looking at it histologically, and I'm looking at this and I'm saying, well, okay, right here, we put a stain on it that's supposed to stain connective tissue blue, and it's staining it red. What's going on? And I found a paper from the 1970s saying that the stain that we've been using to look at connective tissue, if the collagen is stretched, the staining qualities change, so that when the collagen isn't stretched, it stains blue. And when it is stretched, it stains red. So when we're looking at the lesion in the tendon where there's been increased stretching of the tendon, it's red, okay? And again, here, this is actually a different site in the same tendon that's farther up here. So where we see the lesions, we're seeing increased stretching of collagen.
And that, if you'll forgive me, that's that excessive tensional loading.
Right. Well, it's anything, compression will do it too. Okay.
Okay.
So if you have because collagen, bone also has collagen in it. Okay. So here is, let's say this is the normal structure of it, and you you either pull it or you compress it, it's going to do this to it.
Wow.
Okay.
Thank you.
And that's what we're seeing across the board. What was nice was, okay, we see it in the tendon. And if you look at this, the tendon looks a little bit more crimped than here. And there's some other stains we can put on to show that basically the tendon is stretched right here. Also in the fat pad underneath, where you'd have the increased force hitting it, the collagen in the fat is staining red. And in places where there's not so much force, it's staining blue. But what really got me was the bone, because in navicular bone, we see damage right along here in this surface of the bone. And here is showing that this is actually a lesion in the lesion in the cartilage. Cartilage should stain blue, okay? And if it's staining red, it means that there's been some stress, mechanical stress put on this, in this case compression, but it still stains it red. What surprised me was here is normal. So this is bone. The bone is staining red in the navicular case, and it's staining blue or purple or mixed in the control. So what this is saying is that there is an increase in stress on the navicular bone. We know it's related to compression by the tendon. So we actually can pick up evidence of mechanical stress in the tissue, either compression or tension. And again, that fits with the biotensegrity model pretty well. So if we put it all together, the pathomechanics of navicular disease really supports a biotensegrity model, in that the functional anatomy of the whole area is involved in dispersing forces throughout the fascial network. And when it gets overloaded, we start to see damage to those tissues, all of them, not just the bone. And the way to relieve it is that, again, the biotensegrity paradigm would say that the whole body biomechanics affects the posture. And in particular, what happens is that this area is where the forces get concentrated. So the foot gets hyperextended and we've got overloading of the navicular. The tissue pathology fits this really well. We're seeing evidence of increased tension and compression, and also the individualized whole body biomechanical rehabilitation, which is what would be predicted to be successful treatment by the Biotensegrity paradigm, has been very successful in cases of navicular syndrome, even in those considered untreatable by the body as machine paradigm. So again, you have a lot more places to go treatment-wise with by exploring the Biotensegrity paradigm. There are very good reasons to do it. There are some really tragic consequences that both for humans and for horses that have come from the body of machine paradigm and the widespread belief that you just have to treat the pain, that's the primary therapy for arthritis. It has directly contributed to the current epidemic of opioids epidemic in people and in horses. The belief that giving these anti-inflammatory drugs to race and show horses, and often it is the only treatment that the veterinarians will offer, has resulted in catastrophic breakdowns. So for example, in 2016, the first 181 days of 2016, 180 racehorses broke down. In 2015, 953 horses died on the racetracks, and they estimate that 90% have evidence of chronic pre-existing injury. Now, why has it gotten so bad recently? Well, because there were veterinarians believed, and there was one in particular, who lobbied to get the dose of painkillers, a painkiller called Bute in particular, increased so that racehorses could run on higher doses of painkillers. Well, that got approved, so the racehorses started running on higher doses of painkillers, and you had catastrophic breakdowns as a result. The veterinarian who was pushing this actually quit his practice and said he thought he was helping horses. And again, this is just absolute disaster in terms of what's coming out of it. Realize too that the current veterinary paradigm can't go anywhere but give, except to try to do things like drill holes in the navicular bone, or some of the other surgeries they come up with are even worse, okay, and give painkillers. That's really all that their paradigm leads them to. Okay, moving on. This is where I have to thank Susan because when I was reading her book, I was going through, she has all these wonderful examples of tensegrity and models. And I started to think about the models and what we actually see in terms of tissue. And I had been thinking that, okay, the biotensegrity paradigm is, one of the obvious applications for it is musculoskeletal disease, but could it also be explaining a lot of the issues that we see in other types of organ and tissue pathology? And that's what I'd like to just give you a couple examples of where I've been thinking about this. Now, first off, you have to understand that because
Betsy,
yep.
Betsy, can you go to that previous slide?
Yep.
And what is that, a dog, and what's going on?
I will be explaining all the examples.
Oh, okay, great. Sorry, they're such great.
It was just to whet your interest.
Teaser.
So I'll go over them. It's a teaser. But you also have to understand, again, is a kind of theme on this, is that how we've been looking at things have been able to look at things, not just how the paradigm, but how we've been able to look at things has really been restrictive. And so a few years ago, this article came out, a new organ that could explain the mysteries of the human body, and they're carrying on, and it hit the news. And what was it? Fascia. Okay. Which is the largest organ in the body. And generally we don't cover it in veterinary medicine, either much in anatomy. Michelle does, because she's into it. And certainly we don't in pathology. Okay. So, but you have to understand part of the reason why, which is that if you look at this is an H&E, this is a standard histological section of skin. And again, we're looking at two-dimensional view, very tiny piece, and it's about 10 microns thick. Okay. So when you're looking at the fascia and the collagen here, it just, doesn't look like much. And you can't really appreciate what it looks like in 3 dimensions, which was also by Dr. Gambrio. It's actually like this. It's like, I describe it as sort of a fluid-filled bubble wrap running everywhere, okay? But we can't appreciate that in how we've been studying tissue, okay? So I also had a colleague that I sent the wonderful movie Strolling Under the Skin to her, and she came back to me and gave me a kind of dirty look and said, that blew my mind. Blood vessels aren't supposed to move. So it was like, don't bother me with this. It messes up my worldview. Okay. And that is one of the things we have to be careful of, or try to get by as we change paradigms. Okay. Mm-hmm. So what's going on with the dog? This dog has a disease called Ehlers-Danlos, which is caused by hereditary defects in how collagen is being made. Okay. Traditionally, if you look for papers like this one, this is actually not the same case, but it shows a similar thing. These animals and humans, and it has been described in a variety of different animals and humans, and there's several different forms of it, as you might imagine, because there are lots of different ways making collagen can go wrong. But they have skin hyperextension. They also have joint hypermobility. The skin can be easily damaged, and they have abnormal wound healing. Those are the standard way, what you see, and that's what you're seeing in this dog. It's hyperelastic skin. Now, traditionally, we pick up it's got hyperelastic skin. If you look at it histologically, you don't see a whole lot. You can put a special stain on and say, well, there's a little more proteoglycan or something else there. So what they do is they go look at it here, and then they go to EM. Okay, so if you're looking at the collagen structure in EM, again, you see a nice tensegrity structure in how the collagen is formed. And you see in these cases of Ehlers-Danlos that the collagen isn't being made right, and you don't get the nice collagen strands. And that's how I learned the disease. But then when I was looking at, again, Susan's models, and you think about the tensegrity model, string and strut models, it comes closer, you start to think, what's going on between this? Why does this produce this? Okay. And again, with the strolling under the skin and Dr. Gambarier's work, is that you understand why this leads to this, okay? Because the strings, if you will, are not being made right and they're not connecting right, okay? So it makes this disease, for me, a whole lot easier to understand. It's like, oh yeah, Ehlers-Danlos, something messed up with how the collagen is made. But I think it's a good example of how the biotensegrity paradigm can fill in a big missing piece between stretchy skin and EM level lesion, which was about all that we could do with this in the past. So then, she also talked about spirals, and the heart is a spiral, something we haven't always understood, but there was a recent article that had some, was pointing this out. Again, a lot of times you'll see articles or you'll see observations. Well, biotensegrity explains that, but they don't go there because the paradigm hasn't been fully incorporated. But if you start looking, you see evidence everywhere. So here you've got fiber pattern and performance, and basically the heart, when the heart beats, it's like squeezing a dish towel. You're squeezing one direction and the other. And that twisting action pushes the blood out, greatly increases the capacity for the heart to push blood out. So what happens in failure? Well, the heart gets rounded and the spiral loosens up. Okay, so here is the normal. It's why the heart is the shape that it is, and it's not a big ball. Okay, so in heart failure, you start to see a change in the orientation of the fibers, and it changes the contraction. So what about the lung? Well, you'd think the lung is a pretty good organ to be thinking about tensegrity, and indeed there is a paper on it, because what is the lung doing? It's expanding and contracting all of it at once. So it's in that ability to do that and to really balance the mechanical stresses within the parenchyma are really, parenchyma is the tissue, okay, really is essential for very even ventilation. And what they found is if something damages an area of the lung, so here there's an area that doesn't expand as much as it should, it's too small. Here's one where it's expanding too much, okay, that can set up imbalances in how the tension is managed through the lung tissue. And interestingly enough, the area where you see these problems, and it could be the residual damage from an infection or from something like asbestos or other things, is that you see the highest stress right around where the tensegrity architecture has been disrupted. And that's shown here. This is a case of what they call acute respiratory distress syndrome, and they've actually been measuring the stress. So you see areas in the lung that are stressed. That again, is that due to the fact that you've lost the capacity for the lung to evenly expand and contract throughout its cycle. That also can explain a disease that when you see the term idiopathic, it means we're idiots and we have no idea what's going on. So there's a disease in the lung called idiopathic pulmonary fibrosis, which is characterized by progressive pulmonary fibrosis, and they don't know why, which is why they're calling it idiopathic. But if you think about how the lung, the tensegrity structure of the lung, and you have some area that's damaged, all right, this area is damaged so it doesn't expand. Well, what happens is that puts stress on the adjacent area, and we'll talk about what that can do. And eventually that area can expand. And so the whole fibrosis progresses through the tissue. You can see that here. You've got, this is the alveoli, or the distal part of the lung. You see fibrosis going along here. Well, this now can't expand as much as it used to. And that's changing the stresses across the tissue. If you look at it, and again, when you start looking for evidence of biotensegrity and function, I'll start looking for things like collagen and cross-linking. Okay, so here in the healthy lung, no, these are complicated, the main picture, but the main thing to look at, the main thing to look at here is these are the collagen fibers. Okay, here they are, and you see these cross links. Okay, so what's happening, and this is across diseases that impact the lung, they're all characterized by more collagen and more cross-linking. And all of that is going to restrict the ability of the lung to move, to expand and contract as it goes through breathing cycles. This is a similar pattern to what we see across other tissues. So you've probably heard of a disease called cirrhosis. So what happens in cirrhosis is you've got increased stiffening of the liver matrix, okay? That leads to excessive deposition of collagen. The collagen aligns and cross-links, and you get stiffening of the tissue, okay? And once you have stiffening in one place, that stiffening can then expand because the tissue adjacent to it can't move as well. What's different about how we've been thinking about it is that they've shown that the matrix stiffens before you get fibrosis or scarring. We used to think that the matrix stiffening was caused by the fibrosis and scarring. So basically the stiffening, the stopping of the movement happens before you get fibrosis. So they're now looking at it to say, is it possible that we can change the matrix mechanics to try to control some of this progressive fibrosis in the lung? Similar situation in the kidney, which is what I was showing you before, which is we have interstitial. Interstitial is the tissue between the glomerulus of the kidney and the tubules. And this was a case in a dog that I had not that long ago. Here, the connective tissue is stained blue, the normal tissue in the tubules is stained red, and look at how the fibrosis is just infiltrating around the normal structures. This is another way to look at it. This is highlighting the collagen fibers, and you can picture that, again, Susan, everything moves, that tissue needs to move, and part of it is getting stiffer. And as it gets stiffer, it gets scarred. So we're seeing that across organs.
Wow.
Okay. Now, the other thing just came out this year, got a renal urologist kind of excited about it when he learned about tensegrity, because you know that the glomerulus filters the blood. And what happens in kidney failure is the filter doesn't work so good. The way it's working is that there is a basement membrane in the glomerulus, basically a lining in it. And then there are these cells that have called podocytes. They have foot processes. And the foot processes push on this membrane, which can be leaky. So they put pressure on it. And when they put pressure on it, it restricts how much fluid can move across it into the urine, from the blood to the urine. What happens in disease is that you lose these little processes, so you don't have as much compression on this basement membrane, and it leaks more. Okay, so again, common thing, compression, disruption of normal compression and tension throughout the tissues. Okay, it's even been, they're talking about tissue stiffening in chronic diseases, and you've probably heard of mechanotransduction. So you've got mechanical forces that move across the cell, they change gene expression. Well, what they're finding that's really important is what happens if this tissue matrix, the extracellular matrix, gets stiffer. And in cancer, for example, you've got the regulation of tissue homeostasis, as they call it. It's regular. And that what happens is the extracellular matrix starts to, the collagen in it starts to line up and get stiffer. And that's allows the cancer cells to metastasize, to invade the tissue. Basically, it allows them to invade the tissue and move on. Okay. So this has come out in other observations too. I mean, they had, and again, this was something we couldn't pick up in our two-dimensional fine section bits in looking at tissue. But as they've moved to more three-dimensional imaging, we've actually started to see that. So they had these mice, they put a little port in the tumor that they could look at microscopically. But they could also, because it was still in the living mouse, just had a little port in it, they could see things more in 3 dimensions. And they actually saw the collagen fibers lining up in the matrix around the tumor, and the tumor cells moving out along them. Okay, so a lot of observations have supported this. They've also found tissue stiffening in cancer, obesity, heart disease, diabetes, lung disease, and kidney disease. And it's led them to propose that tissue stiffening is a major factor in the development of chronic diseases. And so they've been, proposing that you want to start, adding therapy. Also that the tissues stiffen as you get older, which can explain why some of these diseases are more common in older people. So if you look at the tensegrity paradigm, if you look in health, you've got mechanical interactions in the environment, integration of body structure and function. It also explains, species differences. It explains fascia and management of the extracellular matrix. You've got mechanotransduction. And again, paraphrase Susan, everything must move in normal health. In disease, the paradigm implicates the fascia. It allows us to study diseases better at the organ and tissue level instead of just at microscopic. And again, stiffening can explain progressive fibrosis. It also identifies the matrix structure and mechanics as therapeutic targets, which is again what they are working to develop. And as you know, the matrix structure in tissues is not linear elastic, it's more viscoelastic. And again, those properties are all based in tensegrity structure. Another thing that's really, to me, starting to it really provides extra support to the biotensegrity paradigm is that you look into the engineers who are trying to mimic the qualities of tissues, and they're having to go, they're mimicking them by putting in qualities of tensegrity. So they've made an artificial stent for tracheas, and it actually has oxidic properties. That allows it to work better than just a regular stent. And also in blood vessels, just like those finger traps, if you look at the structure of the smooth muscle in a blood vessel, it looks a lot like a finger trap in terms of it being woven. And they are also finding that when they're making artificial vessels, the woven structure is what works the best. So finally, as a comparative pathologist that's looking across species, my interest in the biotensegrity paradigm is also because, can it explain species differences in disease susceptibility? And if you look at the naked mole rats, they were the vertebrate of the year in 2013. Their form of hyaluronic acid, it has a very high molecular weight. They've shown that the soft matter properties of this hyaluronic acid has anti-aging properties. It's anti-cancer. It actually inhibits cancer cells. And again, they're working off the cartilage model of joint disease, but the joint cartilage in naked mole rats is more resistant to trauma-induced damage. It also forms very highly folded structures that vary with the organ. And this is, you can show these properties again with oobleck, which Susan introduced me to, in that the properties of this hyaluronic acid can be mimicked by looking at oobleck. So again, here are the soft matter properties showing up in a species difference. And then also this was one that's pretty interesting. When grizzly bears hibernate, the heart rate decreases and the cardiac output decreases to the point that if it was a person, they'd be dead. So how do these animals manage that? Well, they do it by actually changing the form of a protein called titin, which is found in muscle fibers. It acts like a huge spring, okay, in the muscle fiber. It's one we haven't really picked up well on electron microscopy, so it's actually fairly new structure. You don't see it in all of the indications of the sarcomere, but it's this huge spring. So what they do is when they're hibernating, they actually change the form of it to a form that's stiffer. And the neat thing about that is that's in the same individual, so that they can change the form. Basically, they use a stiffer form of a spring that allows them to survive the low heart rates and decreased cardiac output. And titin is also another site that other hibernating animals modify a little differently than the bear. And it's mutated in familial cardiomyopathies, some familial cardiomyopathies in humans. So it fits this very well. So finally, if you compare the two paradigms, body of machine model can't explain the diversity of life. It can't explain structure and function. Predictions don't fit observations. The emphasis has been on parts. In other words, let's replace the damaged part rather than on a whole body context. And it really, what we're left with, it was a useful paradigm for a while, but what we're left with is the diseases and structures and all that it can't explain. And in contrast, the tensegrity model gives us the flexibility for evolution, integrates structure and function, and the predictions better fit observations. It also gives us a paradigm to use to move into studying matrix mechanics in particular, which we haven't had with the body of machine paradigm. The matrix was just a way to stick stuff together. That was it. Whoops, so, sorry. So basically, we're researching horses, and I have an incredible team to work with. We're also looking, one of the projects, we're looking both in disease projects, but also we're investigating tensegrity or biotensegrity in the horse-human coordination, and the engineers are really, they've made tensegrity models of human spine and horse spine, and we're looking at connecting them together and adding force to one and how the other responds, to just see if this is a way that can explain what we see. So thank you. I've probably gone longer than I should have, so I apologize for that. But take any questions.
That is amazing. I love your geeky sign off. That's the best. Before we take questions, I just want to say, I'm just stunned. I really am. It's just amazing. That was wonderful. We will be taking questions, and the way we'll be doing it, everybody, is if you could use under reactions in Zoom on the bottom panel, if you could just do a raise hand, and then it comes up in our list in order. If you cannot find that, then you can always pop something in the chat. And before we do the Q&A, we're just going to briefly jump over to Graham, I believe, or Chris, you're going to do the sponsors. Is that right?
Yeah, that's right. Thanks, Susan. So once more, as always, we like to thank our sponsors. since the very beginning of the Biotensegrity Party, our first sponsor was Handspring Publishing, and they are offering us a coupon code for a discount on all of their fabulous books. I know Susan's book that Betsy has mentioned many times, Everything Moves, is published by Handspring Publishing, as are many others. And Graham is here, many more that we see. We also have Artifact Pro, and they give us a coupon code as well. Gwen is going to put those codes in the chat for everybody that's here on Zoom. Pretensed is Daryl DeYoung's company. He also makes fantastic tensegrity structures. So Artifact Pro and Pretense, there's where you can go to get your tensegrity structures. The Fascia Hub, and they are, Jan is here as well, I think. The Fascia Hub has a deadline here that they'd like us to announce. Gwen will also put that into the chat, I believe. There's a coupon code for you there, or you can find it on our Biotensegrity Archive newsletter. And finally, Embodied Biotensegrity, that is the platform that I run with Gwen. And we've got lots happening right now. We're offering a coupon code that Gwen will put in the chat for our membership program. We've got some courses and stuff coming up later that maybe we'll have the opportunity to mention after the Q&A. So back to you, Susan.
Thanks, Chris. Thanks, Chris. George, your hand was up first, but I'm going to give seniority to Steve. Also, I don't know when he has to leave for family wedding festivities. So I know that you won't mind, George, just hopping in the back seat for a second. Go ahead, Steve. Steve, you're muted. You cannot unmute. Is that something?
He's
There I am.
unmuted now.
I'm in now.
All right.
Elizabeth, you didn't just make my day, you made my year. You made more than that. I mean, I've been working towards this goal for 40 some odd years to get a pathology, anatomy, medical use of this thing that I've been working on for 40 years. And I've brought it into orthopedics, but I haven't really been able to do the same thing into the other fields that you've been able to do, and certainly not at the level that you've been able to do. And I really can't tell you how much this means to me. It really brings tears to my eye and joy to my heart. I thank you so much.
And
Well,
to Michelle as well, because some of that
And
work.
Michelle, of course.
Yes.
yeah, well, it's you got to start it. And I think timing, one of the things that probably made it harder for you was again the problem in how we're looking at things. Because now the engineers are getting into it. We can model things in 3 dimensions, and we just couldn't do that before. So it changes a lot. But thank you for getting it started. It's, you know, I just started looking at how it can explain things, and I came up with most of what I showed you, not the navicular stuff, but after that, only in the last couple months. So
Well,
it's got a huge potential.
Yeah, well, I've been anticipating this all these years. I just haven't had anybody else to be able to work with on this.
Yeah.
You know, I've talked about many of these aspects that you've talked about, not knowing the details that you know, but just assuming that these things were happening at these different levels. And now, you know, now we're ready to, the opportunity is here now. And I'm so grateful that somebody's picking up the ball and running pretty fast too.
Yeah. And you were so kind to mention my book so many times, but I have to say, none of that would be in my book without Steve.
Yeah. Well, the reason that what your book did was give me an idea about what to look for and how to model it. Okay. So that you know, that was that in terms of looking across the diseases. What it did was say, okay, well, let me try teaching a course. And again, I can hand the students some models. And then I started looking for diseases that would work in the models. That's why I was grateful to how you did it, because I was saying, okay, here's the property. What does it mean? And do we see a problem with it in disease? That was the course it sent me on. So.
And I'm really honored, because for those of you who don't know, we believe it's the first college level course in biotensegrity ever that Betsy's been teaching this semester. And how's it going, Betsy?
Let's say it's intellectually really stimulating and also panic inducing, because it's like, where am I going now? I mean, I had him build your model of the string one with the coffee stirrers, and I showed him the strolling under the skin, and then somehow Ehlers-Danlos popped in, and I was going, okay, all right. You know, and then it's just, you know, it just went like that. I had presented some on, I'd been trying to work into more diseases than the musculoskeletal, because I really thought that it's going to explain stuff we have not explained before. And so I was working on ways of trying to get in there and also to sell the idea, which is why the models are so important.
Thank you.
So,
George, my ears pricked up, particularly at the end when Betsy started talking about the matrix mechanics. So probably a good time for you to jump in.
Well, thank you. That's a great presentation. I appreciate that. And to note, we have now we've had about 14 veterinarians take my program. I don't know if you're familiar with matrix repatterning, but currently we have a veterinarian who's also a medical researcher primarily. So he really is not a practicing vet. He works more in medical research. He's part of our scientific advisory board now. And we started a study with Sunnybrook Hospital in Toronto last spring before the pandemic hit, on looking at, speaking of the glomerulus, and he's a nephrologist, and I treated one of their staff who had chronic hypertension, was not resolved with any conventional medication. And you know, we talked about the fact that she remembered that exactly when it started, she had a very bad bike accident. We treated her, and her blood pressure has been perfectly fine. So the focus was on hypertension, and I thought of the glomerulus and the kind of dissipation of that pressure control, the foot cells that were lost. And I think of the expansion, all the organs that I've noticed in terms of this impact trauma causes this expansion. And that may explain why you see that, you know, in movement of ions out of the membrane becomes less competent, right? And so that's exciting to see, you know, in that context. It makes perfect sense to what we've seen. And we've been able to help people. One of the first cases I treated was idiopathic thrombocytopenia. And we've had a number of successful cases because we've actually been able, we believe, to normalize the spleen, which then allows for regulation, proper regulation of both platelets and white blood cells. But going back to horses, I've done a lot of work with horses. And one of my questions to you is, have you considered the influence of the horseshoe in terms of disrupting the biomechanics of the foot? Something I've noticed quite a lot in my practice, that when we rehabilitated horses, part of what I found consistently working at the racetrack, for example, the breakdown would resume as soon as they started training. And I kept on tracing it back to the foot. And then we started looking at horses who were rehabilitated to barefoot. And all of those problems, once we were able to rehabilitate them, disappeared. And so racehorses typically in North America they break down after the age of 5, maybe, if they're lucky. In Australia, they're running barefoot and they're racing into their teens and they're winning all the races, right? So I wonder if you considered the influence of the horseshoe. Is that something?
I have been. I mean, what I was thinking again, when I saw the article on the tracheal stent, where they made it oxidic. In other words, it would move with the tissues. And I wondered about that with the horseshoe, that you need something that will do this more. They know it has to, then they know that the foot has to expand, but you know, some kind of material that would allow more of that motion would probably be quite helpful. I've been a little hesitant to focus too much on the shoe because there's been so much focus on the shoe rather than on what's going on with the rest of the body. And so I think that it has effects, and hopefully at some point they're working it with human running shoes and stuff too. They're putting this oxidity property into it. And if they come up with a shoe that will do that, that would probably help. But they've been neglecting the rest of the body. I mean, that cartoon I showed you, I mean, I just shake my head. It's like they just look from here down. And part of it is they don't have the knowledge base. They didn't need to know how a horse is supposed to move and how it moves when it's being most efficient, like we've studied with human athletes. They just don't do that because it hasn't been in their paradigm. They haven't needed it. Okay. And so I've been a little hesitant to push issues with the shoe until that gets resolved. But I agree with you that, you know, I see it sometimes in my own horses, that the ones that are barefoot will have fewer cracks, for example.
So I just, on that note, I mean, just to look at the history of the horseshoe, you know, that's a very recent intervention, roughly 2,000 years ago. And, 25 million years of evolution. Romans and Mongols all used, barefoot horses. And the Romans apparently, before a campaign, would put them into paddocks with river rocks to condition the hoof, improve circulation and tensile strength, and trim the foot. Yeah. Mm-hmm.
Yeah. The other thing, though, you have to realize is that what we've done to the horses by selective breeding since, in that you've got these thin-walled hooves on horses that are 18 one hands, and then what we're asking them to do. So I think it's like they have this with the barefoot running in people and versus shoes. So I think you can have shoes that can work very well. I don't think we've done that well.
Yeah. I have a barefoot trimmer I've worked with over the years, and she's so dedicated. She was a farrier, now is a barefoot trimmer. She literally carries a bag full of cadaver specimens of horses that are shod versus unshod, where they're cut down in a sagittal section. And you can see the condition of the joints in horses that are in their 20s that have absolute perfect integrity of the articular cartilage when they're barefoot, if they were raised barefoot, versus horses that have been shod. And they're the same size hoof.
Yeah,
I think some of this.
But that isn't well controlled because you don't know how those horses were used.
No, these were hardworking horses.
No, but I mean, you have to really say that is the main part. You have to have horses that were worked exactly the same way.
Oh, absolutely. All I'm saying is we've had so many horses I've worked on. We've gotten them out of the shoes. It takes a long time to rehabilitate them, sometimes 6 months to condition the hoof, and then they're happy horses. But anyways, I think it's all a conjecture until we do a control study, like you say. Now, the other thing I wonder.
Hold on, I just want to say while we're still on that, before you move on, George, is that during the colloquy, this came up as well. Yeah. And there's a great article that's very easy to find if you Google like police horse shoeless, that the Houston police force has shoeless horses, or it's also, some of this is more filled out in the discussion at the end of the colloquy. Sorry, George, you had another question?
Yeah, that's great. What was the outcome of that comparison?
Oh, that's what they're doing in Houston. They have a whole of the police horses are not wearing shoes.
So that's an interesting comparison. Then, if you look at horses that are in the police situation with their shod versus unshod, have they come to any conclusion as far as their health?
I think if you look, I haven't seen the article since July, but
Yeah.
they're healthier, happier.
Yeah, for
So,
sure.
but
And I think part of
since
it,
we are stopping in about 15 minutes.
okay, just quick.
I want to
quick
make sure
question.
you get to your other
Yeah.
question.
Of course, the other question is about changes in bone structure on trauma, like repetitive trauma in horses or other injuries. Are you aware that bone does expand with injury, or is that something you're familiar with and changes the mechanics of the joint as a result?
Well,
It's an instantaneous change. It's a non-linear, as Stephen would say, non-linear event, because we've reversed that. We've on X-ray.
well, actually, what they found is that bone gets stronger when it's loaded, and it probably should expand when it's loaded, just like the tendon expands when it's loaded. So, that's part of probably the normal structure. And the issue, some of the issue with, again, the horses that have been rehabbed is it's a practical one. It's that if you have a lame horse and they've done all these diagnostics on it, okay, to find out why it's lame, and then, and this has been John Luke's work, so he looks at how the horse is moving and rehabs it, and then we don't always get follow-up on what has changed and what hasn't, because the horse is sound. So why would you pay for all that imaging?
Well, we have measurably shrunk the bone and caused almost immediate improvement in biomechanics and reduction in pain and inflammation. So I'll, at some point, if you're interested, I can share that with you. But anyways, that being said, yeah. Okay. Thank you very much for your input.
Yeah.
And
Sounds like you're doing some interesting work. Yeah.
yeah, Steve's hand is up again. Go ahead, Steve.
Yeah, I just wanted just to put in that I worked on tensegrity stents. I wrote an article with Richard Gordon and Geshuber on triggered nano degradable stents, tensegrity stents back in 2011. So they're finally catching up to me again.
That's great.
It's the engineers. They don't have so much baggage. They make it doesn't work. So then they try something else.
Yeah. Their job is to just be in competition with finding what works, and they don't really, they're not culturally motivated to be repeating.
Yeah, or they're not stuck in the paradigm we've been stuck in, because they'll immediately toss what doesn't work.
Yeah. Jan, did you want to unmute and ask your question, or?
Oh, thank you very much. I was just interested, Betsy, in how your students who'd come on the course, maybe not expecting a diversion from traditional biomechanics, how they responded to your biotensegrity introduction.
Most of them, like I teach, I slip it in when I'm teaching bone pathology to the vet students. They generally get it and like it. And to be honest, some of them are saying, they're following around the clinicians and all they're doing is injecting joints and they're not happy with it. So from the students, I get really, really good responses. The course I'm teaching is actually to freshmen. It's a part of a research seminar series that they do. And I'll admit, both with the vet students and the freshman students, is, I'm going to send them off to the other courses with something that they're not going to get, and that's already happened a little bit. But I was talking to one student just this week. She was saying, well, she wished she knew more biology so that she could follow this even more. And I said, well, when you learn the biology, you're probably not going to hear this. But that didn't seem to bother her, so that, for example, one of the things that actually maybe looking into more is there's a disease, muscular dystrophy, or Duchenne's muscular dystrophy, which is due to a defect in dystrophin. It's a protein that lines the muscle fiber. And I've had cases in a cat and looked into it, and they didn't know what it did, just lines it. Well, it turns out that it connects the muscle fiber to the fascia. And they don't, and again, without understanding, as soon as I could say that to a student, she was like, oh, so you could see the significance of it. Whereas in the other paradigm, it's just, well, it connects to the fascia, but we don't really know what it does. So I think so in general, the response, again, from the students is, that's why I suppose, going with them before they get invested in the current paradigm. You know, if you're making a living injecting joints or using a certain procedure, then it's a little harder to change. But if you get them coming up and just, think about this idea, and the models have been a big help too, trying to get things across. So
You're training troublemakers, Betsy.
I am. I don't know quite how it's going to work, but it's just plant the seed, and you don't need too many of them to take off with it. But there is a discontentment about the ineffectiveness of a lot of the approaches to treating horses. And again, we never seem to consider their athletic function in like we do with athletes, in human athletes. And it just makes no sense to me. It's like, you've got to look at how they're moving and what they're doing.
Thank you. We're going to try to cram more questions in. Kimmy, do you want to turn on your camera and unmute? And then after Kimmy, we'll have Celeste.
I can unmute, but I can't turn on my camera. It says someone else has to do it. But I'll go ahead with my question. Thank you very much, Betsy. This has been just a fascinating presentation. And I was wondering if you could describe some of the whole body treatments that are used with the horses when they have this navicular disease. I mean, do they try to reposition the rider? What kinds of things do they do?
It's exactly the same thing that they do with human athletes, in terms of you look at the horse and you look at how it's functioning. Is it got too much weight on its front feet, for example? So then you work on balance. And a lot of times for many of the diseases, it's rebalancing and conditioning. So it's not, again, it's not really any different than the way they assess human athletes. It's just that the sad thing is so few people do it with horses. And part of it is there's a really rigid equestrian technique that is incredibly resistant to change.
Yeah.
That's the real problem right there. They're all trained the same way, and it's just, they're so resistant to change. It's sad. But, and again, just think about, if they're assessing a person's athletic function. So for example, and it's looking at how the whole body is being set up, let's say, what they're doing with the fascial training in humans. And the person who really does this is Jean-Luc Cornille. The way he got into it was, he found that the same exercises that you use to improve the gaits in horses also rehab lameness when they're done right. So it's a set of exercises to improve movement function. So
That's great. And there's that discussion of light touch too, that it relates to when we see Jean-Luc. It's a lot like what we see with Feldenkrais. It's a lot like what we see with so many of the modalities, where it's what the work Jan does, the work Kimmy's done, where it's a light touch and a connection that is allowing that redistribution to move from the sort of pathomechanics, as you have called it, Betsy, to the sort of more integrated, distributed.
Well, I can show, if I share screen for just a minute, I can show you one image that, what we're working on now. And it involved a horse that I actually rehabbed, but it was incredibly enlightening when I did this, which is that if you look at here, this is me with my mare. And we're working in hand. We've put the measurements in because we want to use some of this in a grant, and you have to put enough of traditional biomechanics in, I think, to So that's why we have these, but it does show that, you know, they've synchronized movement to you very well. And what I realized is that when I contracted my front line, or my back actually contracted the back, she did exactly the same thing immediately. And so when you're working to rehab them, you can use your Biotensegrity, they will mimic it. So it's the same thing you see when people, at least this is our theory, it's the same thing you see when people synchronize their movements. They're not even thinking about it. So I got to wondering if tensegrity synchronization, whole body tensegrity synchronization, was part of the coordination between horse and rider. And then if, you know, we're looking at ways of investigating this, that's why the engineers have been making models for us. Because what I found is that all I have to do is put tension in and the horse immediately mimics it. Immediately. So that's the other way you can use that. They mimic your movements very quickly, and you can use that to help have them, you know, to rehab, which is what I did with that mare, because she was club-footed and twisted around the foot. So I could correct it by getting her synchronized with me and then correcting the dysfunction. And it worked amazingly well. I'm still in awe because I was kind of like, good grief, they've been doing what I told them to, signaling them to do all along. And I always thought it was them. Oh, she's contracting because she's tense. And it was no.
Hey, there's a lot going on in the chat. Of course, the Tellington T-Touch also has been using the light touch, and Maren Deal talks about this in her book as well. And she'll be with us on December 3rd. We're going to do a tea party with her presentation from the colloquy and the Q&A we did not get to have that day, and discussion. But before we sign off, I want to go over to Celeste.
I want to thank Betsy so much. You're the biggest reason I'm here this morning. Seriously, because you are one of the few people with a DVM after your name who is stepping out of the box. I am not medically trained. I am an equine therapist. And I run into and have run into the things you have talked about year in and year out. The last thing you mentioned, I can't tell you how many times I will work with restriction, tension, fascial lockup in a particular part of the horse's body. And the owner will say, oh my God, my right hip is out of whack too. And I, you know, for years I've been saying, the horses are fine without us. We're the problem. We're the problem. But the other reason is we have a brand new wet behind the ears vet school that just started here in Tucson. And I would give both my arms to try and bring the biotensegrity concept to their attention. And I haven't got a clue how to go about it. And I'm wondering if after this, you and I could maybe be in touch.
We can. I think one of the sad things, what I see is that we're losing the clinician researcher. So, you know, and there are lots of reasons for it, but that's one of the reasons that, you know, things haven't been explored more than they have. And so then everybody's, you know, they're busy, they're not thinking about it. They don't have time to think. They're just applying what they've learned to do. Often in the same way. And and then research has gotten such a bad name because it's kind of hard to do. And we've taken, you know, you need time to think is the big thing. So one of my depressing things is I watch my colleagues, they're all going into administration. And I'm just like, don't you like the science anymore? You know,
I mean, I constantly run into the joint injection. That's
yeah.
all it is. And then with the farriers and the feet, I mean, I come last after the vet, the owner, the farrier.
Yeah.
I am nothing in that mix.
Because
And
you're
yet trying to get
massage-
people
it's
to
just-
look
just
at
for
the
people-
entire horse.
For people
Yeah.
who don't know, Celeste, you're a massage therapist, equine
Yes.
massage. Yeah.
Yes,
Yeah.
yes. I mean, trying to get people to look at the entire horse, it has been an 18-year battle, Betsy.
Yeah, well, I wonder, you look at what happened with human medicine, which was there were a rise of all these other professions to deal with what, the classic medicine wouldn't deal with. And it may end up being the same in vet med. So part of it is to say, and I know as somebody who teaches in the vet school, they have they're not prepared in terms of the training they've had to look at this. And the paradigm hasn't said they needed,
And part of the
to know
trouble
about
is-
fascia or to know
Yeah.
about soft tissue. And there's still one clinician I was having a discussion with decided that the problem in navicular disease where the foot was run under, he said that when women wear high heels, their Achilles tendon gets short. And so he wanted to do something like that with the horse, that he thought the reason that they run under like this is because their tendon's too long. And I was like, I said, no, it's their
I
body
know.
posture. No, it's the tendons too. He was serious. I was like,
Yeah.
Luckily, I don't think he had figured out a way to cut a piece out of the tendon, and hopefully he never does. But that is what some of them come up with, so, like drilling holes in the, I could have told him as a pathologist that was the worst thing they could have done, because the holes would have filled up with fibrosis, and you haven't done anything about the pressure. And that's exactly what happened.
Yeah, but
I'm also imagining that guy didn't spend a lot of time himself in high heels.
No,
but he was an expert.
come
He was
at this.
he is an expert on the horse's foot.
Wow.
But
Okay,
you can come
I'm
at
going
this,
to-
Betsy, with a DVM after your name. I count for nothing in this mix.
Well, they do if it makes you feel any better, I'm a pathologist, not an equine practitioner. So there's still a barrier for me. There's a lot of stuff they don't want to hear, and they're too busy. I mean, to give them credit. So what you have to look for is to find a few that are enlightened and want to do better. And that's why I've been trying to get catch the students.
I'm going
and to give them to whatever, life is, particularly as a clinician, is really tough. It's hard. And I think, Steve, you had a great quote about that, about how you had no time to think. That's a big part of the problem.
I'm going to just jump in because we're going to be signing off of YouTube. And before we do that, I want to mention that in the chat, George Roth has very generously put a discount for a training of his that's coming up. You have to be a qualified practitioner to take that, but George promises me that someday he'll develop a foundational seminar for people who are not trained as therapists. And also, for those of you who are interested in my book, and thank you, Betsy, for mentioning it, Body Biotensegrity, we're going to be doing over the course of 5 months, we're going to be doing, starting in January, another course based on my book, where we're going to be on for January, off for February, on for March, off for April, on for May. So you really get time to integrate the information, and that there's discounts on that, and that's in the chat. We have other coupons that are in the chat. If you've missed them, maybe we can put them in again, because I know one of them is for the fascia spine that Jan has coming up with the Fascia Hub. So with that, I am going to say, Betsy, thank you so much. Maybe we can do one more toast and toast goodbye to our YouTube people, and everyone is invited to hang out for another 20 minutes or so for an after party for the people who are here with us on Zoom.
Susan,
So-
can I
Yeah.
just jump in and say to anybody who's watching live on YouTube now, or maybe who is watching in the future, that if you want to come and join us on Zoom and join us for the after party, the way to find the registration for that is to go to biotensegrityarchive.org and to sign up for our newsletter. We put out the registration link usually the Wednesday before we go live. Yeah.
Yeah, and this is an all volunteer production. The archive does accept and is grateful for your donations just in support of its educational mission. And I think, Chris, your coupon, your discount is good until December 7th. And Jan,
I gotta
yours-
clarify that for you, Susan. So
okay, yes, please.
that 15% off is an early bird rate for your course till December 7th. But you'll find that actually on the landing page. The coupon that we have offered for 15% off is to join Biotensegrity Trailblazers. That's our membership group. And our members, the Trailblazers, they get the best discount on your course. So if you're thinking about doing both, become a member first, because they get a really great discount on the course. So
They do.
just to clarify.
Okay, that's great. Thank you so much. Well, Betsy, I'm going to raise a glass to you and Michelle and the work you both do together, and Jean-Luc and the other people on your amazing team. Thank you for a fabulous presentation, Betsy. Biotensegrity is alive and well in Athens, Georgia.
Well, thanks for the interest.
Thank you.
Betsy. That's wonderful.
Cheers.
Thank you.
Cheers.
Thanks for a great presentation, Betsy. I've got so much I'd love to talk to you about. Oh, shoot.